People think dental work fails because it was bad dentistry. Sometimes it is, but more often, dental work fails because it was built on the wrong plan. You can have a dentist who performs the highest quality of work, but if the treatment plan is not correct, it will never last. Example, a beautiful crown is placed perfectly, but no attention was placed on the patient's bite dysfunction. And because of that, the crown develops a cavity prematurely or the crown breaks. Your diagnosis and treatment plan matter, and they matter at the highest level. If we don't evaluate the big drivers, gums and bone, tooth structure, bite forces, and aesthetic constraints, then we can't predict the stress the dentistry will face. Risk-based, diagnostically driven planning models explicitly emphasize these categories to improve predictability. Planning, it's not paperwork, it's predicting what will break first and designing around it. The second reason, infection, inflammation is not being controlled. Gums, decay, peri-implant disease. You can't build long-term dentistry on top of active disease. If your gums are inflamed, or your pockets around the gums are active, or decay risk is high, dentistry is living in a hostile environment. For implants, the consensus language is clear. Peri-implant mucositis, which means inflammation without bone loss, or peri-implantitis, which means inflammation plus progressive bone loss around an implant. Peri-implantitis is basically gum disease that's around implants, and it can cost you the entire implant to be lost if it progresses. For teeth, secondary caries remains a major reason that restorations get replaced in many studies, especially in higher risk patients. The third reason, bite forces not managed. Occlusion, or the science of bite, pair function or habits that happen outside of function, such as clenching or bruxisming or nighttime grinding. I'm gonna say it again because it's important. Your bite can destroy dentistry. With implants, the risk from occlusal forces often shows up as technical or mechanical complications. Loosened screws, fractures, chipping, especially when bruxism is present. Bruxism basically means clenching or grinding your teeth often at night, creating high forces or long periods of stress. So if you've broken dental work repeatedly, you don't just need a new crown, you need a force strategy, occlusion design or bite design, sometimes splint therapy and monitoring. Next, the wrong material or design for the job. Materials, they matter, but not the way Instagram thinks they matter. It's not zirconia versus porcelain in isolation. It's what material and design best fits the risk. And the risk includes how much tooth structure is left, how strong is the bite, is whether the patient a grinder, whether the gums are stable. Technical complications in implant prostheses have been cataloged for years. Screw loosening, fractures, chipping, highlighting that design and maintenance are part of real-world success. Dentistry fails from fatigue, like bending a paperclip repeatedly until it breaks. So design choices reduce repeated stress. Reason 5, patient habits and biology aren't factored in. This is where high-level transparency really matters. It's important that when we sit and talk about your treatment goals, you are honest about your lifestyle habits, your health history, and that you follow the instructions that we give you to optimize success. The best dentistry in the world still lives in your mouth. If someone smokes, has uncontrolled diabetes, has dry mouth, or doesn't attend maintenance visits, risk goes up. For periodontal and peri-implant stability, supportive care and risk factor control are emphasized in guideline summaries. Smoking cessation and diabetes control are specifically referenced as part of your supportive care recommendations. Risk factor control means changing the drivers that keep inflammation active. Reason 6 is no maintenance system, whether you have teeth or titanium. Here's what I tell patients. If you think dental work is a one-time purchase, you'll be highly disappointed. Maintenance, it's not punishment, it's a protection plan. Making sure that you come in for your regular recare visits and you really take your home care seriously and you follow instructions is so important. And also following how often or how frequent we tell you to come in, whether it's every 3 to 6 months, it's really important because we base that and it's dependent upon your specific risk profile. Reason 7, incomplete diagnosis, missing the real cause. Sometimes the failure wasn't from the dentistry at all. It was from what was missed: a cracked tooth, a high bite force pattern, a periodontal pocket that wasn't diagnosed or seen, a hidden decay lesion, an airway or muscle pattern that's driving clenching. When diagnosis is incomplete, treatment becomes reactive instead of a strategic plan. And strategic is where predictability lives. A complete diagnosis is like a full set of labs before you go have any type of surgery. Without it, you're just guessing. Reason 8, rushed dentistry. Good dentistry takes time. Not because we're slow, but because biology has timeline. Tissues take time to heal. There's temporary stages that guide final outcome. Rushing tends to show up later, such as marginal leakage or decay underneath your crowns, inflammation, fractures in ceramic, aesthetic failures. If you've had dental work fail, you're not cursed. Most failures have a reason, and when we can identify the reason, we can design around it. If you want clarity, book a comprehensive evaluation. I can tell you exactly what category the risk lives in, whether it's gum and bone, tooth structure, bite forces, aesthetics, or a combination, and what I would do to make the next version last. Failures, they're not random. They're predictable when you measure the right things.